Hello, everyone. I'm the Director of Fertility Preservation within the Division of REI, Women and Infants Hospital of Rhode Island, which is part of Brown Medical School. I'm seeing the majority of the reproductive age cancer patients referred for fertility preservation, and my research focuses on improving utilization of oncofertility care. I'm going to be presenting on research that was performed using Rhode Island-specific health care claims data. Rhode Island was the first state to pass the medical fertility preservation insurance mandate in 2017, and we're interested in understanding how this impacted fertility preservation utilization in the state. My knowledge of Max. Huh? Sorry, I'm used to using Max.
Yeah, no.
Oh, there we go. Okay. So it's that one? Yeah. Okay.
There you go.
Perfect. Sorry about that. I'll be discussing how the implementation of the fertility preservation insurance mandate in Rhode Island impacted the utilization of care in the state. So I'm going to be talking about how this impacted REI consultations, procedures, and fertility preservation testing for reproductive age breast cancer patients. So just to give you some background, the Rhode Island fertility preservation mandate was implemented in 2017, and it only covers commercially insured plans in the state. It is important to note that 50% of reproductive age patients in the state of Rhode Island are on commercial insurance. So it only is going to cover 50% of cancer patients in our state. The rest are on federally funded plans, which are excluded from the mandate. So we use claims data from the Rhode Island All Payers Claims Database, which covers about 85% of the state population, and it includes information from commercial and non-commercial insurance payers. So the Medicaid patients are also included in this database. Our inclusion criteria included women aged 14 to 43 with newly diagnosed invasive breast cancer from January 2011 through 2022. All of these women that we analyzed received chemotherapy as part of their breast cancer treatment and had continuous insurance coverage after their breast cancer diagnosis. So we didn't want to include patients that would have dropped off their insurance and then may not be reflected in the database later on. We used the Social Determinants of Health 2020 database to analyze the socioeconomic status based on the participant zip codes that were in our Rhode Island claims database. And then we compared the post-mandate versus pre-mandate utilization of fertility preservation services, and we stratified by the insurance type, commercial versus non-commercial. So these were our results. I know it's a little bit small. We identified approximately 1,000 Rhode Island resident reproductive breast cancer patients, and only 469 met our inclusion criteria. For the various reasons I talked about before. They had to have continuous insurance coverage. They had to be on chemotherapy as part of their treatment. We found significant demographic and socioeconomic differences in the post versus pre-mandate time periods in commercially insured and non-commercially insured patients, as you would expect. There were older patients in the commercial versus non-commercial insurance, specifically in the pre-mandate period. These are all statistically significant differences. The median household income was higher in the pre-mandate time period compared to the post-mandate time period, and the income was also higher in commercially versus non-commercially insured patients in both time periods. There were a higher percentage of patients who had bachelor degrees in the pre-mandate versus post-mandate, as well as in the commercial versus non-commercial groups in both time periods. So this is probably the most important slide that I wanted to share. This slide displays the results of only commercially insured patients, because these are the patients that are going to be impacted most by the insurance mandate. You can see that there is a trend of a higher percentage of fertility preservation testing. So the blue is the pre-mandate, the, I guess, red-orange is the post-mandate. So you can see in the post-mandate period for fertility preservation testing, you have about 13.5% of these eligible patients that are pursuing fertility testing versus 8% pre-mandate. So even though this actually was not a statistically significant difference, you can see that the numbers are trending up over time. Here is the results of our segmented logistic regression modeling, where we looked at factors which impact consultation, REI consultations, or testing alone. We found that utilization of testing increased over time, so about a 3% odds ratio per month as time passes by. However, we did not find that the utilization of the mandate impacted consultations or testing alone. So it wasn't specifically related to the mandate, but we did see the trend increase over time. Age, as other speakers have mentioned in previous talks, was inversely related to utilization of testing and services. So younger patients are more likely to utilize fertility preservation services. Although we did not find that fertility preservation utilization changed directly by implementation of the insurance mandate, we did see a trend towards increased fertility preservation testing in commercially insured patients, and our logistic regression suggested that there was more utilization over time. We found that commercially insured patients were more likely to have higher median household income and bachelor's degrees compared to non-commercially insured patients. Across both time periods, pre and post mandate. The reason we may have not seen an impact in fertility preservation utilization directly attributed to the mandate may have been the COVID-19 pandemic, may have decreased utilization during services, like the critical years after the mandate. It was implemented in 2017, and COVID obviously hit very soon thereafter. So that may have impacted our results. And there also were some demographic shifts in the state that may have also contributed to that. We did see lower socioeconomic status post-mandate. I didn't share this, but we saw higher comorbidity indices in our commercially insured patients post-mandate as well. And that may have contributed to the lack of changes that we saw. We must continue to follow trends over longer periods of time due to the potential lag in utilization after implementation of these mandates. So it's not that we're going to see changes 2 to 3 years and say, hey, this mandate improved utilization. It really does take time. Providers need to be educated, insurers need to be educated, and it takes time to see the differences. And I believe that qualitative research in the form of physician-patient surveys, interviews, could help explain some barriers to utilization after these implementation of these mandates. It may just not be only cost. There may be other barriers that we have to learn about, and using claims databases, it's going to be very hard to understand some of these barriers. So I think it's really important that we combine the quantitative research with the qualitative research to understand what these barriers may be. And these are my acknowledgements.